All right, let's dive right in. Today, we're stepping inside the mind of a surgeon. We're going to break down two real-world case files and think like a doctor to figure out the critical decisions that can literally mean the difference between life and death. So, let's get started.
When you think about surgery, you probably picture the operating room, right? The bright lights, the intense focus, all that drama. But the truth is, some of the most important moments happen long before the first cut is ever made, and long after the last stitch is put in place. That's where the real magic and the real risk lies.
So let's start at the beginning, the pre-op puzzle. This is where doctors have to be detectives, looking for clues and trying to solve problems before they even have a chance to start.
Okay, let's open our first case file. We've got a young man who's scheduled for what everyone thinks is a routine surgery. But here's a little secret from the world of medicine. There's no such thing as routine. Every single patient is a unique puzzle.
So here's our guy. He's 28, coming in for an elective appendectomy. He looks great, feels great, no issues. The only thing on his chart that even raises an eyebrow is a history of well-controlled asthma. Seems like a pretty minor detail, right? Well, in surgery, there are no minor details.
Now let's look at the evidence. We're seeing a few things here. FEV1 and FVC are just measures of how well his lungs are working, and they're perfectly normal. His blood count, his electrolytes, everything is right down the middle of the fairway. On paper, this patient is the picture of health. So, where's the hidden risk?
And that brings us to the crucial question. You're the doctor in charge. You've seen the patient, you've seen the labs. What's your call? Do you just proceed as planned, or is there a move you need to make right now?
The correct move is to give him a single dose of IV steroids. Now, I know what you might be thinking. Why? All his tests look great. But this is a perfect example of playing chess, not checkers. This is all about proactive, preventative medicine.
Here's the key. The stress of surgery and anesthesia alone can be a massive trigger for someone with asthma. It can cause their airways to suddenly clamp shut. That's called a bronchospasm, and it's a full-blown emergency in the OR. So that single dose of steroids isn't treating a problem he has now. It's preventing a potential catastrophe from ever happening.
And this is why those other options are just wrong. Doing nothing? That's just rolling the dice. Giving him bronchodilators? That's like using a fire hose to water a houseplant. Total overkill for someone with no symptoms. The art of medicine, right here, is finding that one precise action that makes all the difference.
Okay, so we solved the pre-op puzzle, but the challenge is far from over. Now we're jumping into the post-operative period, where the mission changes. It's no longer about anticipating a problem, it's about correctly identifying one that's just popped up.
Let's meet our second patient. She's a few days out from a big operation. She's supposed to be getting better, but she's not. New symptoms have appeared, and the clock is ticking to figure out exactly what's going on.
So here's the situation. It's day 3 after her colon surgery. She's got a low-grade fever, her belly hurts a little, and her gut just seems sleepy. Now, importantly, her surgical wound looks fantastic, no sign of infection. The X-ray, though, shows her bowels are swollen with air and fluid. These are our clues.
Okay, detective, what's your diagnosis? Looking at all the pieces, what is the most likely thing causing her symptoms? Is it a disaster, or is it something else?
The most likely diagnosis here is postoperative ileus. Now, this is actually a super common thing after abdominal surgery. The real test, the critical skill, is being able to tell the difference between this and something way more dangerous.
So what is an ileus? Basically, the stress from the surgery stuns the bowels, and they just temporarily stop working. The best way to picture it is like a traffic jam in the gut. Everything just slows to a halt for a little while. It's expected, and it almost always resolves on its own.
Now, here's why getting this diagnosis right is so incredibly important. You have to rule out the absolute nightmare scenario, an anastomotic leak. That's when the part of the bowel the surgeon reconnected starts to come apart. But look at the clues, they just don't fit. A leak means severe pain, a high fever, a rock-hard abdomen. Our patient's symptoms are mild. This is the art of clinical differentiation.
And we can confidently cross the other big suspects off our list too. It's not a wound infection. The wound looks clean. It's probably not an abscess, which would likely show up later with a much higher fever. And she has 0 of the classic signs of a blood clot in her lung. All the evidence points in one direction, ileus.
So we've cracked 2 cases. We've been through the pre-op puzzle and the post-op mystery. What's the big picture here? What are the core lessons we can walk away with?
It really boils down to two fundamental principles. First, anticipate and prevent. The absolute best way to manage a complication is to stop it from ever starting, just like we did with that dose of steroids. Second, you have to differentiate and diagnose. You have to be a master of reading the subtle clues to tell the difference between a common speed bump, like an ileus, and a true 5-alarm emergency.
And that really just leaves us with one final thought. We've only peeked behind the curtain at two very specific situations. It makes you wonder, doesn't it? What other hidden risks, what other subtle clues, and what other life or death decisions are doctors navigating every single day to keep us all safe?